Amitabh Banerjee, sir. Sir, could you tell us, in case of unavoidable medical complication, how should communication with the patient and family be handled to maintain trust? Please.
This is most important, sir. There have been studies that if the patient is transparent, there has to be transparency. The complications are there, the prognosis are there, and there have been studies when the doctor has communicated, and also in case of an error, instead of trying to hide it, good communication, and patient is also part of the treatment decision. There are less litigation, there are less CA. So communication is important in a particularly serious case. If time is taken out to talk to the relatives, talk to the patient's relatives, because patient may be very serious. So there are less chances of litigation, and there are less chances of violence against doctors. They have done studies and they have found out that patients do not litigate doctors. Patient do not litigate the medical errors. Patient litigate the doctors. There have been cases where the one doctor has made an error that radiologist failed to detect a early tumor, and the patient sued the surgeon. And when asked, it wasn't the fault of the radiologist, the patient says, no, the surgeon was very well behaved. He explained to me, the radiologist was rude to me. So these are some of the things which has come up. And if there are too many lack of communication, doctors go into defensive. I mean, if there are too many litigations, too many violence, doctors go into defensive, and sometimes it harms the patient as well as the profession. There have been earlier cases. There are sometimes, as a serious patient, as you said, with complications, there may be certain measures which may be taken, I mean, calculated risk. There is a risk, but it's a calculated risk. And if there are too much of distrust between patient and doctor, no doctor today is ready to take a calculated risk. I have personal experience. I have started my career as an anesthesiologist, and after some time I switched over to public health. But serving in remote areas in small hospitals, a couple of times I did replace, when the anesthetist was not there, I did replace the anesthetist even after 10 years of gap or 20 years of gap, and I could save the patient. But today I wouldn't do it again, because nowadays the distrust is so much. If something goes wrong, I could save the patient, and today I would not tell anyone in my position to do it, because if something goes wrong, there are a lot of documentation, lot of cases that you are not supposed to do it. You are out of practice. You are no longer anesthetist. In fact, once I was the anesthetist, and it was a gynec's place. They were bleeding. The patient was bleeding heavily, and it was a service officer's wife who was a radiologist, and there was no gynecologist or surgeon in that remote hospital. So she did the surgery. I did the anesthesia, because she had done house job in gynecology some years back. She said she can do it. So we could save a patient, but today such patients will not be saved, because there is so much of distrust. There is no between patient and doctor. So once, if you can involve the patient and there is a good communication, many of the problems can be solved.
Thank you, sir.